Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me. For those of you who are not familiar with my channel, I am a board-certified psychiatrist and expert psychopharmacologist with nearly 3 decades experience diagnosing and treating mental illness, and I specialize in helping people navigate psychotropic medication trials. So before I forget, please be sure to check out my private online academy at notonanemptymind.thinkific.com, where you'll find some of my best premium content. Also, if you learned something today, please take 2 seconds to hit that like button so that other viewers can also find this video. Do a good deed if you learned something and you'd like for other people to have a greater chance of coming across this presentation. Today you're in for a treat. Today I'm going to tell you what I know about carbamazepine, otherwise known as Trileptal. Should Trileptal be used in psychiatry? We shall see. Carbamazepine inhibits the release of glutamate, the major excitatory neurotransmitter in the central nervous system. So blocking glutamate leads to a dampening of neuronal activity in the CNS. But Trileptal's main mechanism of action is as a voltage-gated sodium channel blocker. It also blocks calcium channels. Trileptal is a way of dialing things down, which makes sense because carbamazepine is an anticonvulsant, primarily and only approved for use in the treatment of epilepsy, the raising of the seizure threshold to make convulsions less likely. This is its only FDA-approved indication, although it's commonly used in various neuropathic pain syndromes to dampen the sensation of pain from damaged or irritated nerves, pain not from a third organ the nerves are innervating, but arising from the damaged nerves themselves, neuropathic pain. And Trileptal attenuates bipolar mania, making it a potentially effective mood stabilizer, or at least in theory. It wouldn't be my first choice, more on that later. Now, this is a bit esoteric. I almost cut this part out, but it has to do with the mechanism of action, so it's super important. How else can we understand how this medication works? And also for you providers in training out there who are also my target audience. So stay with me. Don't worry if not all of these terms are familiar. I'll do my best to convey the core concepts. Sodium channels are literal canals, pores, through which sodium and other ions travel through the cell membrane from one side of the cell to the other. In this case, from the outside of the neuron to the inside, passively, down the concentration gradient, because there's more sodium extracellularly outside the cell. There's a phospholipid membrane separating the inside of the nerve cell from the outside, and the element minerals sodium and calcium, tiny charged atoms, single atoms, not molecules, traverse that membrane. Atoms themselves are neutral, but sodium ions have a charge of +1. Calcium carries a charge of +2. It has to do with how many electrons are missing. And that dictates how these cations interact with other atomic species to make molecules. But it also affects the electric potential difference across cell membranes, in muscle as well as nerve tissue, the so-called resting membrane potential. And with nerve cells, neurons, this difference in electric potential, aka voltage, just like in a battery, affects the likelihood of that nerve being stimulated enough to induce an action potential down the length of its axon and on to activate the next neuron. It's beyond the scope of this video, but if you've studied a little neuroanatomy, you'll be familiar with how nerves conduct electricity. All you need to know here is that by blocking these ion channels, the flow of sodium ions through those pores is impeded, which makes it harder to conduct electricity from one neuron to the next. Again, very useful when we're trying to prevent seizure activity, diminish pain sensations, or reduce agitation. Broadly speaking, there are 2 types of ion channels. Both are protein structures consisting of integral membrane proteins, meaning they're embedded within the cell membrane, folded into specific 3-dimensional structures to form a transmembrane pore or channel through which ions can flow down their electrochemical gradients, anchored within the membrane by amino acid sequences called transmembrane domains. So 2 types, ligand-gated and voltage-gated. Ligand-gated channels are opened when a ligand binds to a specific site on the channel. Ligands are molecules that bind receptors. With ligand-gated channels, a ligand binds to the channel, which leads to a conformational change, a change in the shape, the actual 3-dimensional structure of the proteinaceous pore. This in turn opens or closes the channel to the flux of ions. Proteins are dynamic molecules. They can exist in multiple conformations, each with a slightly different shape, and that affects their function, whether we're talking about a receptor, an ion channel, or an enzyme. Okay? Simple. That's not the kind of channel we're talking about here. Here, with Trileptal, we're talking about voltage-gated or voltage-sensitive channels. All voltage-gated means is that instead of a molecule, such as a neurotransmitter, physically attaching to the channel, what determines whether the pore's, so to speak, gate is open or closed to allow or disallow the flow of ions are changes in the voltage itself, changes in the electric potential difference across that channel. With voltage-gated channels, the conformational shape-shifting occurs in response not to molecular ligands, but to depolarization or repolarization of the cell membrane, changes in the amount of positive or negative charge on one side of the membrane compared to the other. Remember, this is the potential difference of voltage, so it's not the absolute amount of charge on either side, but the difference between them. The inside of the cell is normally negative with respect to the outside, at rest. This has to do with the relative concentrations, in this case of sodium and potassium, largely, among other ionic species. Sodium has a +1 charge, and there's an abundance of it outside the cell, whereas potassium, it's mostly intracellular. The cell membrane is said to be polarized. When positively charged ions flow into a cell, the inside becomes less negative with respect to the outside, and that's called depolarization. This depolarization can affect those voltage-gated channels, which, as their name denotes, again, are sensitive to depolarizations, opening them to allow more cations to flow into the cell, further depolarizing it in a positive feedback loop that can lead to the complete reversal of polarity, where now the inside of that segment of a neuron's axon is net positive with respect to the extracellular space just on the other side of that membrane, and an action potential is born, carrying depolarization onto the next axonal segment and eventually to the next neuron. So you can see where too much uncontrolled activity of this kind could lead to seizure activity, such that blocking these channels with a drug is a good way of raising the seizure threshold, reducing the likelihood of a grand mal seizure. Both ligands and voltage changes affect whether the gateways are open or closed. In our case, Trileptal is acting on those ion channels that respond to changes in voltage. So that's what we mean when we say that Trileptal blocks voltage-gated sodium and calcium channels, preventing the flux of sodium and calcium ions into the nerve cells in response to depolarization. Bottom line, Trileptal effectively closes those gates, blocks the pores to the transit of ions. The nerve is essentially numbed, and that's very conducive, or rather not conducive, pun intended, in conditions such as epilepsy and neuropathic pain syndromes. And so by blocking the release of glutamate and blocking the influx of sodium and calcium, especially sodium, we get a dampening, a quieting of the nervous system, which is also theoretically useful in bipolar disorder. And so Trileptal is used as an anticonvulsant, an analgesic, and a mood stabilizer, although the latter two are off-label uses, not sanctioned by the FDA. The FDA has only approved Trileptal for the treatment of partial seizures in adults with epilepsy, as monotherapy all by itself, or adjunctive therapy, adding it on to other anticonvulsive treatment, as monotherapy for partial seizures in children ages 4 to 16 with epilepsy, the immediate release preparation only, as adjunctive therapy for partial seizures in children ages 2 to 16 with epilepsy, again, the immediate release form, and the extended release formulation is approved for the treatment of partial onset seizures in patients ages 6 and older. I won't get into all of these different types of seizures, but they're all specific seizure types. However, when we say that Trileptal is only safe and effective as monotherapy for partial seizures in children ages 4 to 16, and should only be used as adjunct therapy in children younger than that, we're only saying that the FDA has made these determinations based on research presented by the manufacturer. This just means that we don't have the research data to more or less establish that the medication is safe and effective. We know that it's safe. There's nothing magical about children ages 2 and 3 years of age. It's just that they weren't included in the cohort that studied the safety and efficacy of Trileptal when it was being used as monotherapy. And so we do have data to support its use as an adjunct in combination with other anti-epilepsy treatments, but all by itself, we just don't have the data. It doesn't mean it wouldn't work. It's always prudent to follow FDA guidelines, however, especially when treating children. There's no reason to be off-label, but every case is different, and off-label prescribing is common practice, especially in our case with psychiatrists in terms of the off-label use for bipolar mania as well as using it in neuropathic pain. It's not as serious if we try it and it doesn't help with neuropathic pain. That's one thing. But if we try it in children and those children go on to have grand mal seizures, that's obviously a bigger deal. All right. So, additionally, Trileptal acts as a use-dependent blocker of voltage-sensitive sodium channels, meaning that it binds to the specific conformational state that the channel adopts when it's open or activated, i.e. in use. So when ions are flowing through the channel because of the shape of the channel, the conformational shape is permissive, Trileptal especially acts for that channel. Trileptal has a receptor and it binds to that receptor, but then it acts upon the voltage sensitivity of that channel. The longer the channel stays open, or the more frequently it opens, the more opportunities Trileptal has to bind and exert its effect. In this way, Trileptal effectively selectively targets cells that are firing at a higher frequency, such as those, conveniently enough, in a diseased state like epilepsy, where they're going off all the time when they shouldn't be, or when nerves are damaged or irritated, sending pain signals in the absence of actual noxious stimuli, while having less effect on cells with normal activity. This is because Trileptal needs the channel to be open or activated to bind and exert its effect. It's a lot like cancer chemotherapy that targets cells that are rapidly dividing, relatively sparing normal tissues. It's the same concept. The medication just happens to target those channels that you're more likely to find on neurons that have an abnormal frequency or abnormal duration of having those channels activated. Trileptal binds to a site on the open conformation of the channel, and it makes the channel less sensitive to depolarization, because depolarization is what further opens the channel. So what we're doing in this case is making the channel less sensitive to depolarization. It takes a greater stimulus. You don't get that positive feedback loop as easily because the channel is less sensitive to that depolarization. And so it takes more of a depolarization to get that snowball effect. And so you can still wake people and agitate them and cause pain and even induce a seizure, but you just have to have more of a stimulus, and that's why you're giving the drug in the first place, to block pain or to block seizures or to block mania. And so a use-dependent blocker in this context preferentially inhibits ion channels more effectively when those channels are repeatedly activated or used. Trileptal's effectiveness increases with the frequency of channel opening or activity. It does all of that in addition to inhibiting the release of glutamate. It's pretty impressive, the things we've figured out. But that's probably more than you needed to know. Let's get on to the clinical significance. Known by the brand name Trileptal, there is a generic preparation available. There has been for years. And the usual dosing range is anywhere from 1,200 to 2,400 milligrams a day in divided doses of 150, 300, and 600 milligrams. There are also extended release tablets in those denominations, as well as a liquid preparation, convenient for small children who have difficulty swallowing capsules. Food does not affect absorption. Carbamazepine is a structural analog of an earlier medication, carbamazepine, also known as Tegretol, another anti-epileptic drug long available in generic form that likewise stabilizes voltage-gated sodium channels in the brain to reduce excessive electrical activity. They're very similar structural derivatives. Carbamazepine is a modified version of carbamazepine. It's not a metabolite, but they're very similar structurally. Doses of carbamazepine need to be about 1/3 higher than those of carbamazepine for similar results. And while Tegretol actually has FDA approval for acute manic episodes, it doesn't have approval for bipolar depression, nor is it formally approved for the maintenance of bipolar disorder to prevent episodes, but it does have FDA approval for acute mania, including mixed episodes. Trileptal, when it's used off-label for bipolar disorder, is usually administered as an adjunctive medication with other anticonvulsants, lithium, or atypical antipsychotics. So we almost never use Trileptal all by itself as a mood stabilizer. And in fact, if I were to see Trileptal monotherapy being used for quote-unquote bipolar disorder or even more bipolar type 2, then I would be very skeptical of the diagnosis because those diagnoses are overdiagnosed anyway, and certainly you can have a placebo effect with the use of any medication. So I would really scrutinize that and really wonder, are we really treating mania or hypomania when we use Trileptal monotherapy? Side effects include sedation and weight gain due to increased appetite. Sedation is dose-related, and it's generally less than what you see with Tegretol. with some tolerance to that usually developed over time when it occurs. Dizziness is also dose-dependent, as is ataxia, which is clumsy, awkward movements due to a lack of muscular coordination. So it can affect the arms and hands, but it can also affect the legs and feet. And diplopia, double vision. All of those are dose-dependent. Note, weight gain is not dose-dependent. You can see weight gain at all doses, including starting doses. And that's true of weight gain almost across the board for all medications that I can think of that increase the appetite. Do so immediately. If they're going to do it, they do it. Doxepin might be a notable exception because you can use really tiny, tiny doses as a hypnotic agent. You don't even induce the anticholinergic effects at that point. And so that may be one reason why you don't see a lot of weight gain at the very lower doses of doxepin, but you do at the higher doses, but that's the exception. Weight gain is generally not dose-dependent. We also sometimes see nystagmus with Trileptal. Those are rapid involuntary movements of the eyes, the eyeballs. You can have abnormal gait, which is a form of ataxia, confusion, nervousness, fatigue, dyspepsia, and headaches. In overdose, we see nausea and vomiting, somnolence, hypotension, low blood pressure, tremor, and sometimes paradoxical agitation or aggression, probably due to delirium. Even at regular doses, monitoring of sodium levels is a good idea, especially during the first 3 months, as hyponatremia is possible and can be life-threatening. The medication is not habit-forming, but like all anticonvulsant agents, Trileptal should be tapered before discontinuing, especially at higher doses and especially in patients with established epilepsy, to avoid rebound withdrawal seizures. In those patients, usually if we're making a switch, usually neurologists will do a cross taper where they start to wean the Trileptal while giving another medication. And actually, usually, in a lot of cases, you see Trileptal as adjunctive therapy. So even though it's approved as monotherapy for certain seizure types, we see it a lot of times just added on. Neurologists add it on, just as psychiatrists do. And that's a clue right there as to how effective it is. By itself, it's like buspirone, in my opinion. By itself, it's just not very impressive. But Trileptal is easy to wean. Other discontinuation symptoms are uncommon, and even if you abruptly discontinue it, unless the dose is just really, really high, you're not likely to see a withdrawal seizure in patients that don't already have epilepsy, in patients who are not already having some vulnerability to having a rebound seizure. Still, it's not a good idea. Better safe than sorry. Because oxcarbazepine has a tricyclic chemical structure, it's not recommended to be taken with MAOIs, monoamine oxidase inhibitors, a class of antidepressants, including 14 days after MAOIs are discontinued. You gotta wait 2 weeks, and oxcarbazepine should be discontinued at least 2 weeks before starting MAOIs as well. Oxcarbazepine can lower plasma levels of hormonal contraceptives, and so it may reduce their effectiveness there. Women should be counseled to rely on alternate forms of contraception, perhaps in addition to. And there's a potentially significant drug-drug interaction between Trileptal and the antiretroviral drug dolutegravir, an HIV integrase inhibitor. Trileptal can induce enzymes involved in the metabolism of dolutegravir, which goes by the brand name Tivicay, leading to decreased plasma concentrations of dolutegravir. And the clinical significance of this potential interaction is not entirely known, but caution should be taken. There are numerous other potential drug-drug interactions that should be evaluated as well. Controlled studies have not been conducted in pregnant women, obviously, but oxcarbazepine is structurally similar to carbamazepine, Tegretol, which is thought to be teratogenic in humans. Use during the first trimester may raise the risk of neural tube defects. In medical school, I learned that Tegretol can do this, that it is considered teratogenic, and it can cause spina bifida and other neural tube defects or other congenital anomalies. If the drug is continued, patients should be started on 1 milligram a day of folate to reduce the risk of these specific types of birth defects. For patients with bipolar disorder, though, oxcarbazepine should generally be discontinued before anticipated pregnancies. Whereas seizures, even mild seizures, may cause harm to the embryo or fetus, atypical antipsychotics may be preferable to anticonvulsants such as oxcarbazepine or lithium if treatment of bipolar disorder is required during pregnancy. Certainly bipolar symptoms may recur or worsen during pregnancy. We see that all the time, and some form of treatment may be necessary. It's always a risk-benefit analysis. In psychiatry, Trileptal may have its greatest use in treatment-resistant bipolar and psychotic disorders such as schizophrenia as a second or third line augmenting agent, not in monotherapy. So added to pre-existing regimens that are not yielding the response we need, which we're always aiming for complete remission of symptoms. We might also think about oxcarbazepine in those patients who are unable to tolerate carbamazepine, but who respond to Tegretol. We do worry about hyponatremia, particularly in the elderly. So, should Trileptal be used in psychiatry? I've almost never used it. I would certainly give it a chance in any situation in which I might use Tegretol, which I've prescribed many times over the decades. Oxcarbazepine seems to have the same mechanism of therapeutic action as carbamazepine, but with fewer side effects. And the more uncommon but life-threatening risks, such as the risk of leukopenia, low white blood cell count, aplastic anemia, which is basically wiping out the bone marrow, and low red cells, low white cells, low every kind of cells that the bone marrow makes, a fatal condition, agranulocytosis, which is similar. It's a paucity of granulocytes, as well as elevated liver enzymes, which could be indicative of hepatic failure, or Stevens-Johnson syndrome, a potentially life-threatening rash, and other serious rashes. All of those things, which are famously associated with carbamazepine, do not seem to be associated with oxcarbazepine. So it's a lot safer, even though those are rare conditions. They're rare, but they're life-threatening. In fact, skin rash reactions to carbamazepine resolve in about 75% of patients with epilepsy when switched to oxcarbazepine. Oxcarbazepine also has fewer drug-drug interactions than carbamazepine, and really the most significant risk for Trileptal is probably clinically significant hyponatremia, defined as sodium levels less than 125 millimoles per liter, most likely occurring within the first 3 months of treatment in up to 2 to 3% of patients. It's unknown if this risk is higher than for Tegretol. Also, since SSRIs sometimes also reduce sodium, in that case due to the syndrome of inappropriate antidiuretic hormone production, patients treated with combinations of oxcarbazepine and SSRIs should be carefully monitored, especially the elderly and especially in the early stages of treatment. Trileptal is less well investigated in bipolar disorder, but there is some evidence of its effectiveness in treating acute mania. Oxcarbazepine is included in the American Psychiatric Association's bipolar treatment guidelines as an option for acute treatment and maintenance treatment, according to the APA, of bipolar disorder. Not according to the FDA, but according to the APA. And there is some evidence of effectiveness as an adjunctive treatment in schizophrenia and schizoaffective disorders as well, to calm the agitation and especially manic agitation that you might see in schizoaffective disorder, manic type. Because Trileptal is analogous to carbamazepine, it could theoretically be useful in chronic neuropathic pain if it's given at the right dose for the right length of time, but there was no direct evidence cited. We do have a tricyclic structure here with Trileptal. So it makes sense that it might be helpful, and we should definitely try it off-label if necessary. That is Trileptal in a nutshell. Thank you for listening. As always, questions and comments are welcome.